Hi, I'm Dr. Selina McGee, and I'm here with my good friend, Dr. Nate Lighthizer, and we are going to have a really robust discussion about definitely one of your specialties, glaucoma, and how that can impact our patients that are going in for cataract surgery, and also just talking about glaucoma in general. So I practice in Oklahoma. I have the fortunate to be adjunct faculty with NSU OCO, where Dr. Lighthizer is too. And we have a primary care practice. We see everything from myopia all the way to cataracts, certainly, and we do manage glaucoma as well. So in private practice with a specialty focus also on ocular surface disease.
Dr. Nate Lighthizer. I'm a faculty member and professor at the NSU Oklahoma College of Optometry in Tahlequah, Oklahoma. I've been there for, hard to believe, 14 years now. 1 year as a resident where I did my residency, and then 13 years as a faculty member. I serve in a variety of roles. I'm the head of our dry eye clinic, the head of our glaucoma clinic, and the chief of what we call specialty care clinic, where we do a lot of our cataract, refractive outcomes, PRK, among many other things. So that's a little bit about me.
Perfect. So let's talk a little bit about the experience for our patients that are going into cataract surgery and understanding that journey with the patient. Tell us some things that you have seen work really well. What do you want to set the patient up for expectation-wise? And let's use a patient that has been diagnosed with glaucoma. How does that conversation differ from someone that doesn't have glaucoma when you're talking about cataract surgery?
Yeah, I think education is going to be the key on these patients, regardless of whether they have glaucoma or not, is just taking some time to explain to them, here's the pre-op process. You're not going to see me every step of the way because the surgeon's going to do a great job on day of surgery, but I'm going to see you before, I'm going to see you on multiple visits afterwards, and we're going to be really here together to manage and make sure you have the best outcome. Communication, like anything in life, is really critical. If they have glaucoma, it's even one step more critical because I tell them, you've got multiple conditions that we need to address. We've been addressing the glaucoma, but understand that one can affect the other. And we can do a perfect cataract pre-op, post-op. The surgeon may do a marvelous job, but you still have glaucoma that can affect your visual field. Remember all those side vision tests that you've been doing. So we need to make sure that we manage both and that remember that one can affect the other. And that will gauge our expectations and temper our expectations depending on the severity of disease.
How in depth do you go as the primary care provider before they get to the surgeon on, let's say, a MIGS procedure? And is it possible for the patient to have combined surgery? What does that conversation look like?
Yeah, it's definitely a conversation that I have because I think we need to take an advantage of the opportunity while they're in the eye. It's like anything in glaucoma, it's going to depend on the patient. Yeah. But if they're on a medication or two and I feel we can maybe ease the burden of those medications, we will have that conversation and tell them that we can two birds, one stone. While we're in the eye, it adds just a matter of minutes to the procedure, and we can do a combined cataract and glaucoma procedure. And I always, what would you do, doc? And I tell them, this was my eye, this was my loved one's eye, my parents. I would want to take advantage of that situation, and let's consider a glaucoma surgery as well as the cataract surgery that's going on.
I think it's super important that you lay out the foundation of what the patient's going to experience. And by the time they get to the surgeon, you've already laid out the plan. You're in communication with the surgeon, so everybody's on the same page. The patient has the comfortability of, okay, Dr. Lighthizer already said this, and the surgeon is echoing the same thing. I've heard it a couple of times, and for that communication piece, I think is really key. Mm-hmm. And I want our OD colleagues to understand and ensure that that role is on us. Mm-hmm. And we should take an active role in that, not wait until they get to the surgeon to have all of their options laid out. So because we have the relationship with the patient, we know the patient well. Yep. There's some nuances there in that communication that the surgeon is not going to be able to know in the 7 to 10 minutes when they meet the patient. So I love that you take a very active approach and walk the patient front to back.
And it's not to the point where I'm telling them this is what's going to happen, because that's ultimately in the hands of the surgeon.
Sure.
But if you explain all the options, it makes you look good that, man, my doctor really cares about me, knows all the options. And again, we may go down different roads depending on the surgeon's expertise, what they want to do. But if you present them all the options, it's a big win for the patient.
Agree. And I do the same thing. I don't talk specifically and even about the type of IOL they're going to have. But we do talk about if you want to be less spectacle dependent for intermediate vision, or you want to be less spectacle dependent for distance and up close, then we can customize to the patient based on more measurements that the surgeon will do. But we set the stage, which I think is really important through this. So let's talk about just glaucoma specifically. Why is it so important that patients, have this testing done? What are the tests that you do? There's lots of technology available to us now. Walk us through your diagnosis and how you approach the glaucoma patient.
Yeah, glaucoma is a puzzle, as we all know. There's no one test. If you can invent the perfect test where you put your thumb in something and it tells you if you have glaucoma, here's the stage and here's how long it's going to progress, that would be very valuable, but we don't have that. So we're going to add up, obviously, visual field. We're going to add up the OCT. We're going to take a look at the nerve. What's the pressure, the IOP, the main modifiable risk factor that we have. We're going to add up that entire puzzle. We've added in ERGs. We've added in corneal hysteresis. All these different gonioscopy, and make the best decision that structure and function are showing. I think that's so very important to add up both structure and function. And I think it's important to remember that we have time, a lot of time in glaucoma. It's rarely wrong, if ever wrong, to repeat the testing.
Right.
Get more data, get another visual field, get another OCT, get another pressure check, and let's add up the data. We've got time oftentimes in glaucoma. And then when you pull the trigger, we've got a variety of options now for glaucoma. So I tell them, yes, glaucoma is a chronic condition. It can be progressive. Fortunately, it's a very slow progressing disease much of the time, but we're going to be here every step of the way, and we're going to explain all the options from drops to laser to surgeries to minimally invasive surgeries. And I tell Mrs. Jones, our patient, we may have to use all of these at some point during your chronic condition, but we're going to be here every step of the way.
So here's a question for you. I know you, and we talk about this in the literature too, interventional glaucoma. What does that really mean to you?
Yeah, I think it's definitely where we're going in glaucoma. The days of drop 1, oh, we need more, drop 2, we need more, drop 3. Interventional glaucoma to me is now taking that compliance piece and helping to ease the burden of that, whether it's SLT, whether it's drug delivery, whether it's MIGS procedures, minimally invasive glaucoma procedure. If it was my eye, I don't want to be taking an eye drop day after day after day. We may need to go to that. I tell my patients, again, we're going to have probably drops, probably surgical options, minimally invasive surgical options, maybe even injections as we go throughout your glaucoma continuum. To me, interventional glaucoma is easing the burden with in-office procedures that are minimally invasive, they're efficacious, and they're safe.
So you have a phrase that I love. So walk us through how you communicate with patients when you do SLT. What do you tell them that you're doing?
Yeah, so it's Mrs. Jones, we're going to shoot a laser in your eye. No. This is a very gentle procedure. We're going to do it here in the office, and it works via a little bit of inflammation, and your own body's going to do most of the work. So I've heard some people call it selective light therapy. This is not a laser. We're going to use a light to massage the drain of the eye, kind of tickle the drain a little bit to enhance the flow. Well, now we're tickling and massaging and enhancing. Sign me up for that. So it's all how you communicate and phrase it to patients. I let them know that this has now been proven to be first line. It's been shown to have a lower rate of progression over a 6-year period based on the light trial. And again, we've got options in which way we can go.
Sure. I love how you communicate in your way that's non-threatening. Mm-hmm. And let me just ask this question. When we learn something new, and I'm guessing that that's probably not how you started off talking about SLT the first time you ever said it.
Nope.
Yeah. So it's okay to modify and try some things and see what resonates and what doesn't, and then change and see what lands. So I think that's always an important message for us to share, that how we do things today is not how we've always done things.
Yep.
And we needed to fail and fail fast and be okay with trying new things and it not landing exactly how we want it to
I
land.
adapt all the time. I change things all the time. I recently changed my protocol on a procedure, something I've been doing for 10 years. Now I'm doing a little bit different now, but that's okay. That's why it's the practice of medicine,
Exactly.
the practice of optometry.
Love it. Love it. So let's talk about specifically looking at patients that are expecting to go into cataract surgery and have less dependence on their glasses. Let's pivot a little bit. Do you approach that patient any differently than you do someone that is going in for a monofocal cataract surgery? Walk us through like that conversation, and how do you set up expectations for the patient during that process?
Yeah, it goes back to the communication of telling the patient you have two conditions, and a lot of times they bring it up and going, I would like one of these IOLs that do more than just monofocal. I've heard of multifocal IOLs, premium IOLs. Am I a candidate? And I let them know that you may be a candidate. I'm not going to say one way or the other definitively, but do remember that you have glaucoma, and a lot of times it depends on the stage of glaucoma. If they are more advanced, I will temper their expectations a bit in saying, because you have moderate to severe glaucoma, you may not be the best candidate. The surgeon's going to make that ultimate determination, but just understand those two conditions. Now, if you have mild glaucoma, I'm more comfortable saying there's a reasonable chance that you may be a candidate for this, but it's just setting their expectations, not saying you're going to have this or you're going to have that, because then if they go in thinking and expecting one thing and then the surgeon says something else, now we're backtracking.
Right.
So.
Right. So we've walked through how to set the patient up with proper expectations, and they've had their surgery. Now they're back to us. We're doing the co-management and the post-op care. Usually, I'm guessing same day. It's the same day in our clinic, sometimes one day. And you have a patient that is what I would call 20 unhappy. Walk us through best practices, how to handle that patient, and maybe something that you would do differently, and a conversation maybe you would have earlier. What does that look like for you?
Yep. We do 1 day, 1 week, and 1 month post-ops in our clinic, so we see a ton every Friday. We've got about 20 post-ops. And fortunately, most of the time they're 20 happy, but I let those 20 unhappy patients know that this sometimes takes time to get where we need to go, whether it's a laser procedure or whether it's cataract surgery in this case. And it's okay that's why we're going to be on multiple medications post-operatively, and it's just really easing their mind that everybody heals at a little bit different rate. And while they often mention, well, my friend was great on day one, why am I not? Everybody heals a little bit differently, and just because somebody was great on day one doesn't mean that you won't be great on week one. And sometimes it takes a little bit longer. And again, it's just taking that extra moment to hold their hand a little bit and explain what's going on. I love taking pictures and showing them, here's why your vision's down. You got a little bit of swelling or whatever it is. And showing them that and going, we're going to watch this closely. This is why I have you on this medication. It's why I increased it a little bit in this particular case. But just showing them a picture, educating them, and letting them know we're going to follow you closely. And this is likely going to have a very good outcome long term, and we'll adjust as we need be.
Yes. And I think I always use the phrase, I don't remember who said it, but comparison is the thief of joy. So do not compare yourself to your neighbor, your, colleague, whoever else had cataract surgery, because you're right, everybody heals a little bit differently. And I think you have definitely talked to us about making sure you set expectations from the front end. And my surgeon and I that I work with, we always have this discussion. If we have a conversation before surgery, it's an explanation.
Correct.
If we have a conversation after surgery and we have a new problem, then it's an excuse,
Yep.
right? And we live with that for the rest of that patient's life, and we're the ones that are taking care of that patient and every time they come in. So it is so important to talk about it ahead of time. One thing that I have learned and changed even in the last 18 months is recognizing the role of neuroadaptation and what that looks like for patients from front to back. And with cataract surgery, especially with a multifocal IOL, and really any cataract surgery, even if it's a monofocal lens, it can take patients 6 to 12 months to get the vision that they are going to have for the rest of their life. And I think most doctors and patients both are really surprised by that. And because they had the neighbor that's, I was great day one, right? And
Yep.
so they're super disappointed and want to know, oh my gosh, did I spend all this money for this investment and it's not going to work out, and there's a lot of fear in that. And so when we talk about, you have the same brain and it's a new image, you literally have to, your brain has to lay new pathways to see that new image. And that's different for everybody, and it's based on how many birthdays you've had, and it's based on just the way that all of our individual brains work differently. So it's perfectly okay that yours takes a little bit longer. And so, like you pointed out, it's just so important to make sure the patient has the right expectations from the beginning. We walk through what they want to have the least spectacle dependence on and what they want to accomplish with their surgery, and then we can marry them to that technology because they're married to it for the rest of their life, right? But I have found, just talking about that on the front end, that it can take 6 to 12 months, and it's their brain that has to adapt, and they're going to have dysphotopsias, and you can have negative and positive. Well, I think we should talk about that a little bit, because we've all had the patients that come in and they're like, I have this really dark arc over here to the side, and it's the absence of light. That's a negative dysphotopsia that's really common, and the brain will adapt to that. It's incredible what our visual system is capable of. Or you'll have a positive dysphotopsia, and depending on the lens implant that you have, you may have glare and halos. But if you set that, your brain's going to get used to it over time. But when you don't have to reach for reading glasses and you don't have to put something on to see what you're eating or write a check, those kinds of things I think are really impactful. But that whole conversation around start to finish 6 to 12 months I think is super important.
The word has been what we've trained our students and residents, just reassurance. It's going to be okay. Everybody heals differently. It's communication up front. It's reassurance and caring afterwards. I had what you were just describing, a close friend. He's in our neighborhood, and I recommended a multifocal IOL, and he was 3 months out and still unhappy, describing what you just did, and I just reassuring him. And recently, he's now a little out after 6 months out, and he just texted me last week, and he said, my vision is great. I'm so happy. And it was just one eye that was lagging behind, and he couldn't understand, well, why is one eye doing it and not the other? Just it's okay. Everybody heals differently, and he's thrilled now. But it took him a little over 6 months to get there. So patience, reassurance, and communication is important.
Love it. Love it. Thanks, Dr. Lighthizer, for sharing some time with us.
Thank you for having me.